Thank
Sure,
you for
sure, sure.
choosing this topic.
So, good evening, all. So, my talk of the today is common acid-base disorders. So, I will start with what is the basic meaning of acidosis. So, basically, it is believed that H plus is acid and OH minus is a base. Or in another other convention, anions are acid and cations are base. Now the nomenology is changed, and now we don't call no more alkalosis or acidosis. We use terms like acidemia and alkalemia. So when pH is less than 7.35, it is called acidemia, and when pH is more than 7.45, it's called alkalemia. In other concept, whichever substance donates an H plus becomes an acid, and whoever accepts an H plus becomes a base. So this is the basic structure. So what is the source of acid in the body? So acidosis is just H plus accumulation in the body, which results in the lowering of the pH, and our body assess pH. We cannot able to assess the H plus concentration. So body has a system which assess pH of the body fluids. So protein metabolism generates phosphoric acid, anaerobic glucose metabolism generates lactic acid, fat metabolism generates organic acid and ketones, and carbon dioxide is produced in the tissue level when there is a hypoxia, or in normal condition also CO2 is produced. So this is the source of H plus in the body. So how this acid is buffered in the body? It's by bicarbonate buffer. In one answer, it is the bicarbonate buffer which is the most important buffer of the all process. So normal pH is what, 7.35 to 45. So if there is a compensatory mechanism going on, then pH lies within this range. If there is acute acidosis or alkalosis, the pH goes beyond this range. So if there is a acute acidosis, there will be pH less than 7.35, and if there is acute alkalosis or alkalemia, then pH would be more than 7.45. So ICF, like intracellular space, always have a acidic media. So the pH is 7 for intracellular compartment. Interstitial space, it is 7.35. In veins it is 7.35. Veins are little acidic than the arteries, and artery pH is normally 7.40. So what are the buffers are present in our body? So we have chemical buffers which acts within minutes, within seconds they act. So these are in the blood available. Then comes the lung and respiratory centers which drive the respiratory uh, efforts, and they works within minutes to hours. And then comes the role of kidney. Kidney has a multiple functions, which is the main function of kidney is to buffer the acids, and it works, and it take days and 2 weeks to control the acid buffer. So hemoglobin binds the free H plus. Histidine residue present in almost all the proteins as a part of amino acid, which also binds the H plus. Phosphates, they form the phosphaturic acid, and bicarbonate forms the carbonic acids. Now, if you look into the buffer system of our body, there are intercellular buffers. Main intercellular buffer is a phosphate, you know, ATP. So phosphate is intercellular buffer. Then we have proteins in the inside the cells. For example, hemoglobin you have in the RBCs, and you have amino acids. All proteins are can buffer. If they have histidine residue, they can buffer H plus. Then in extracellular fluid, the main buffer is carbonic acid, which is there in intravascular fluid also. And then you have plasma proteins like albumin in the vascular streams. So in summary, what I am going to tell you is there are two sources of acid in the body. One is diet, which comes from fatty acid and amino acid metabolism. Then there are metabolism in our body which produces CO2, lactic acid, and ketosis. Ultimately, they lower the pH of our plasma, and then these buffers comes into play, which are chemical buffers like bicarbonate and phosphate and proteins. So then ultimately, lungs will do the job, and they exhale the CO2, which is the actual surrogate of H plus. PCO2 is a surrogate of H plus, which is acid, and then kidney handles H plus efficiently. So lungs, they do the job by exhaling CO2 out of the body, which is a surrogate of H plus, and then kidney have to have multiple actions. The one of them is excretion of lactic acids, ketones, and organic acid. Kidney can directly excrete those organic acids. These are weaker acids. Then urine buffers, there are bicarbonate and phosphoric buffers. And then kidney also has a tendency to excrete distally secrete H plus. Then there are excretion of uric acid, which is done by kidney. Reclamation of bicarbonate is very important. It's the same process of acidosis, like loss of bicarbonate is acidosis production, and if you reclaim the bicarbonate, it is actually countering the acidemia. And ammonia generation. The kidney is one of the important organ apart from liver which can able to generate ammonia. Ammonia generation helps in directly excreting H plus molecule out of the body. So role of kidney is explained in this diagram in schematic presentation. So you can see in proximal tubule ammonia can be produced. Ammonia can able to excrete H plus, and then phosphoric acid is produced. Phosphoric acid can another way to buffer. These are the urine buffers: phosphoric acid as well as bicarbonate causing carbonic acid. So in distal tubule we can able to reclaim the bicarbonate. So bicarbonate reclaiming will be creating a alkalemic media, so countering acidosis. And then you can, in collecting ducts, you have direct H plus secretion in alpha intercalated cells. So distal secretion of H plus through ammonia generation is happening in the alpha intercalated cells. We have H plus K plus ATPase or H plus ATPase situated, which can throw out the H plus outside the lumen, and this helps by producing ammonia, because you cannot the H plus will not go out itself. It has to bind with ammonium ion, ammonia, and generate ammonium ion, that is NH4 plus. And ammonia will be created in proximal tubules from metabolism of glutamine. What is the pendrin? It's very important to understand the role of pendrin, because pendrin is situated in the type B cells of intercalated cells of collecting duct, unlike type A cells, like you can see in the diagram. So type B cells mean what will happen once H plus is excreted in by type A cells, then there will be bicarbonate will be reclaimed, and not only bicarbonate will be reclaimed, chloride also will be reclaimed by alpha beta intercalated cells, and this is called as pendrin. So we excrete one of the bicarbonate ion. This bicarbonate ion will be again transferred back to the body by reclaiming in the ENAC channels and sodium potassium ATPase. So we are not losing any bicarbonate, we are reclaiming both bicarbonate as well as chloride ion. So this reclaiming of chloride is very important to understand non-anion gap acidosis. Because in non-anion gap acidosis, chloride is elevated because of reclaiming from the kidneys. So what is the anion gap and what is the concept of anion gap acidosis? So there are two kinds of acidosis, or there can be two methods to generate acidemia in the body. One is addition of an acid. Once there is addition of an organic acid, the anion gap will be elevated. And another way is to develop acidosis is losing of bicarbonate. Whenever there is a losing of bicarbonate without addition of any acid, then in this case chloride will be reclaimed from the kidney, and anion gap will be maintained by rise in the chloride. So that's how we explain two types of acidemia in the body: normal anion gap as well as anion gap. So in this diagram you can able to understand the anion gap. So if you see in the picture, there is an anion gap, which is actually the difference between measured cations and the measured anions. In the second picture you can able to appreciate the anion gap is mainly composed of phosphate and albumin. Now if you see this high anion gap acidosis, there is an increase in the unmeasured anion. This is because of influx of organic acid. Those are weak acids like ketones and lactates and other phosphatidic acids. So these this high unmeasured anion actually becomes high anion gap. And see, in this case chloride is normal. See, in all three pictures chloride is 104. So there is no reclaiming of the chloride has been taken place, but bicarbonate has been reduced from 24 to 12. Now see in this diagram, which is normal anion gap acidosis, there unmeasured anion has been increased, but that has been compensated by, so there is a loss of bicarbonate. There is no addition of any acid going place in this place. So only bicarbonate is lost. That is from 24 it has become 12. Now what happens with the loss of bicarbonate? We have reclaimed chloride from the kidneys, and with the reclaiming of chloride, now chloride has become more than 104. It is now 116, and the anion gap is maintained. So there is no increase in the unmeasured anion level in this point of time. So here comes the role of pendrin to maintain anion gap. How to analyze acid-base disorders in ABG? So we cannot estimate H plus in with electronic machines also. Like in our system, we cannot able to assess H plus. We assess pH. Similarly, in ABG machine, blood gas analyzer, we also cannot estimate the H plus. We assess pH. We assess PCO2. We assess PO2. We assess bicarbonate. Bicarbonate directly measured, and we assess oxygen saturation. Based on this, we apply this Henderson-Hasselbalch equation, and we derive something called as buffer ratio. Buffer ratio is a ratio of base to acid, and with this we interpret H plus. How we interpret H plus? So buffer ratio is basically base upon acid. So the bicarbonate divided by PCO2. PCO2 is a surrogate of H plus because it's an acid. So whenever there are changes happening in the bicarbonate as well as in the PCO2, the pH changes. Based on this principle, we calculate estimated H plus and pH. So this is how ABG machine works. So when the bicarbonate is lost, the pH will be reduced. That is, acidemia has happened. Or when there is a PCO2 rise, pH will be reduced because it is in the denominator side. So pH will be reduced and acidemia will happen. Usually the buffer ratio is around 20:1. So can you predict H plus concentration based on ABG? Yes. So if you see the pH, and if you have to take the two decimals of points of the pH. So if it is 7.40, the H plus amount would be 40 nanomoles per liter. If you reduce it by 7.38, that pH is reduced means acidosis has happened. That means H plus has been accumulated. So you have to add the H plus 2. So it will become 42. If you have increased the pH, that means 7.42. So the H plus has to now lost. So 2 H plus will be lost. So now new H plus levels will be 38. So similarly, you can calculate, estimate the H plus based on the pH. So now let us now see the traditional approach of acid-base disorder and how we interpret it based on ABG. It's all based on one HH equation. So primary metabolic acidosis. Let's first take this. So in primary metabolic acidosis, what's happening? H bicarbonate is lost, so pH will be reduced. So what will happen? Compensation happens in the same direction. So PCO2 will be lost. So how to lose PCO2? By increasing respiratory rate. So lungs will exhale more PCO2. Then this will be the compensatory mechanism. Similarly, in metabolic alkalosis, what is happening? Bicarbonate is getting accumulated. So pH is increased. Again, correction will happen at the same direction. So what will happen? PCO2 is increased. Now it's very difficult to increase the PCO2 of the body, because for that you have the respiratory center has to be shut down, and you should stop breathing, which is not common or not possible. So this metabolic alkalosis is almost never get compensated, because it is not practically possible. Now see the respiratory acidosis, PCO2 is risen, so pH will drop here. Again directions, again the compensation will happen in the same direction. So what will happen to bicarb? Kidney will reclaim the bicarb, because acidosis is happening, so it will reclaim the bicarb. And what happened in respiratory alkalosis? There the PCO2 is lost because of hyperapnea. So what will happen? pH will increase, and then kidney has to lose bicarb here to enable to increase the acid content of the body. So respiratory alkalosis is the most common acid-base disorder encountered in the hospitalized patient. It's very common, may be seen with psychiatric patients as also. Now compensation, how fast does it occur? So respiratory compensation happens earlier. It takes at least 1 to 2 days for the lungs to compensate for a metabolic disorder, but kidney take longer, as I have seen earlier. It takes at least 5 days for kidney to completely compensate a respiratory disorder. Now here are the tips. You have a shortcut, like you cannot always follow the big formulas. So follow the pH and PSO2. If they are following the same direction, it's a metabolic disorder as a primary event. If they are in opposite direction, pH and PCO2, then it is a respiratory disorder. Now there is another trick. You subtract the after decimal points of the pH and compare it with PCO2. If the difference is less than 15, it's a metabolic disorder. If the difference is more than 15, it's a respiratory disorder. See, for example, its pH is 7.35 and PSO2 is 40. So the difference between 40 and 35 is 5. So it's a metabolic disorder. As you can see with bicarb, it's low. It's a metabolic acidosis case. So that was the shortcut. Now principle of compensation should be known. Body attempt to compensate to normalize arterial pH, because body can able to measure only pH. But compensation never returns pH to normal. This is the principle, and patient never overcompensates. If there is overcompensation happening with the formulas, then there is another disorder coexisting. Body by itself cannot overcompensate, and compensation is almost never complete. And we have seen that metabolic alkalosis is not fully compensable disorder. Now there are compensation formulas, like metabolic acidosis. There is winter formula, which is like 1.5 into bicarb plus 8. It is actually a PSO2 measurement with respect to the bicarbonate or lost in the metabolic acidosis. In metabolic alkalosis, what happens? Bicarbonate is accumulated, so PSO2 will be risen. How much it is risen? 40 plus 0.7 bicarb minus 24. But here it is no need to calculate this metabolic alkalosis formula, because I have said earlier it is not many times compensated. It's very difficult to compensate a metabolic alkalosis disorder. So never need to calculate the compensation. For respiratory acidosis and alkalosis, I will give you the better shortcuts than these lengthy formulas. Now compensation shortcuts for metabolic disorders. It's very simple. You just have to match the decimal numbers of pH and PCO2. If those are comparable, that means it is compensated. If they are totally different or fall apart, that means it is acute and non-compensated. See, for example, 7.27 and 25. 25 and 27 is not far apart. That means this is a compensated disorder. But the disorder has to be metabolic at least. That is a prerequisite. Now for respiratory disorder, compensation shortcuts are I call it 14-25, like 1425. You should just remember, like for every 10 rise in CO2 for respiratory acidosis, in acute non-compensated setting, the bicarbonate will increase by 1. For chronic, it will increase by 4. For every 10 millimeter of mercury fall of PCO2 in respiratory alkalosis case, in acute uncompensated setting, the bicarbonate will fall by 2, and for chronic it will fall by 5. So 1425 can be remembered 14-25. Now I will give you some examples to crack. What are the steps to read ABG? So this is example number 1. So suppose the pH is 7.50 and PCO2 is 48. Now you know if it is a metabolic disorder, it is compensated. Okay. Now to know whether it's a metabolic disorder or respiratory disorder, what you have to see? pH and PCO2 direction. So pH is raised and PCO2 is also raised because PCO2 normal is 40. So it is a metabolic disorder. So compensated disorder because the PCO2 and pH is 2 decimals are normal, are equal. So it's a compensated mechanism for a metabolic alkalosis is lead. This is a inference what I have already told you. It's a metabolic alkalosis in this case because bicarbonate has actually risen. Okay. So these are the steps. See the 7.50, 48, it is compensated, and no need to calculate this with step 3. Suppose if we calculate also, let us go to the formula. It is 40 plus 0.7 into bicarb minus 24. Bicarbonate here is 34, so that minus is 10. So 0.7 multiplication is 7, so it's 47. So with formula also you know that it is compensated, and with the trick also you know that it is compensated. Now example second. If the pH is 7.12, what's the direction of the pH? Low, that is acidosis. What is the direction of PCO2? Again low, decrease 8 from the 40 normal. So it is a metabolic disorder. What is the disorder? Acidosis. So it's a metabolic disorder. It's very clear. But if you see the bicarb, you know that it is metabolic disorder. Okay, but by trick also it is metabolic disorder. Now let's calculate the compensation. It was for metabolic. There is no trick is telling that there is no compensation happening. See the minus 12 and 32 is far apart. So with trick there is no compensation happened, right? And now let's the formula. Winter's formula is 1.5 into bicarb plus 8. So that comes to around 22. But the actual actual PCO2 should be 22, compensated PCO2, but the actual PCO2 here is 32. That means there is another disorder existing which is rising the PCO2 from 22 to 32, and that is a respiratory acidosis. So with trick also we are right that the disorders is not compensated, and with formula also we can able to know that there are mixed disorders, and with a metabolic acidosis, a respiratory acidosis is coexisting. Now example 3. The pH is 7.34 and PCO2 65. So pH is dropped, that is acidosis. It should be 7.35. It is 7.34. So acidosis. And the PCO2 is risen, so it's a respiratory disorder because it has a opposite direction. And with respiratory acidosis, you know that PCO2 is very high. So now let's see the compensation happening or not. So the trick is 14-25, 14-25. So this is a compensated disorder or non-compensated disorder. Since pH is not falling in the range, it is an uncompensated disorder. You got my point? It is not 7.35 to 45. If it is 7.35 to 45, then it is compensated. If it is beyond 7.35 or beyond 7.45, it is not compensated. So this is a not compensated respiratory disorder. In this non-compensated respiratory disorder, if you apply the formula, it will come as respiratory acidosis acute. So 1. So for every 10 rise in PCO2, the bicarb should have risen from 1. So here from 40 it has risen 2.5 times. 25 हो गया, 25 add हो गया from 40, तो 2.5 times बढ़ गया. So if you increase bicarb from 2.5, it would become 24. So 24 plus 2.5 will be 26.5. So bicarbonate should have been 26.5, but it is now 34. That means a metabolic alkalosis disorder is coexisting, which is rising the bicarbonate from 26.5 to 34. So this is how we calculate compensation using tricks and the formulas. And these shortcuts are not just shortcuts, they have been now study proven. So this winter formula and the trick has been now correlated with the study. So it's not no more a trick, these are real tricks. Now there is another approach of acid-base disorder. One is the traditional approach which we have just finished. Another approach of acid-base disorder is a base excess approach, which is also called as Copenhagen approach. So this concept of base axis approach is what Copenhagen has found, that whatever is the disorder, the change in bicarbonate is the central point, because we know that bicarbonate is the central to all acid base disorder, and change in bicarbonate happens whenever there is alkalosis or acidosis. So what he has done is, he has determined by various calculations which has been made by computer, that there must be some amount of strong base. If we add that amount of strong base to the blood, the acidosis is neutralized, and that amount of base excess is called as base excess, and that base excess gives us the idea about whether acidosis is happening or alkalosis is happening. So you can also standardize this base excess. These are the machines variables, like ABG machine actually gives you the actual base excess as well as standard base excess, and the standard base excess where there is a correction for ECF. This is the pictorial diagram, but I'll go you with the examples, real scenario example. So this is first blood gas is a normal blood gas. See the base excess there. I don't know whether it's visible. So the pH is 7.46, which is a normal pH. See the bicarbonate is 21, which is actually less. So there is a loss of bicarbonate, and means that there is some acidosis going on. And see the base excess, it is minus 0.2, minus 2.0. So now usually base excess falls between 0 to minus 5. 0 to minus 5. So this base excess here falls between 0 to minus 5, that is minus 2 in this case. So it's a normal VBG. Okay, normal blood gas based on base excess method. If you see a patient of severe acidosis, here the pH is 6.9, very severe acidosis. If you see the VBG in detail, there is CO2 is also risen to 80. So and the bicarbonate is also 12. So there is both mixed metabolic as well as respiratory acidosis going on. In this case, the base excess is minus 16.1. That means the base excess is more negative. That means you need 16 millimole per liter of strong base to be added to neutralize that acidosis. You got my point? What is the base excess theory of Copenhagen means? So in this case, base excess theory tells that there is a severe acidosis going on. Now see the third picture. pH is 7.45, which is normal. Bicarbonate here is 32, which is high. Sorry, 25, which is high, and base excess is in positive 1.8. That means it's not normal. It's not 0 to minus 5. It is in addition. So there is alkalosis going on, and the alkalosis is diagnosed by base excess theory. So this is how this second concept of acid base works. So there are glitches in base excess. It does not work when there are mixed disorders, and once compensation has started, this theory fails, and you cannot able to actually get to the acid base disorder with this approach alone. So you have to always use a traditional approach, which I have already told. So with this, I'll stop the presentation.
Excellent talk, Dr. Saurabh. I must congratulate you. Have made this very complex topic very simple, and I will go listen to your lecture 3-4 times before comprehending all the complex things. But thank you very much. With this, I think we are coming to the end of today's session. We were 1 hour late.